Hello, and welcome to this training presented by the Leukemia and Lymphoma Society of Canada. Clinical overview of immune-related adverse events, cytokine release syndrome, and immune effector cell-associated neurotoxicity syndrome. My name is Natasha Sani. I'm the Community Service Lead for the BC and Yukon region at the Leukemia and Lymphoma Society of Canada. Before we begin our main presentation, I'd like to share with you our mission and present some resources that may be useful to you and the people you serve. At the LSC, our mission is to cure blood cancers and improve the quality of life of those touched by blood cancer and their families. We listen attentively and with compassion to the challenges faced and can point individuals to the information specific to the type of their blood cancer or treatment. We help them get organized to manage and take charge of their care, and we can identify services that would be beneficial for them. Please visit bloodcancers.ca to find the contact information of the community service lead in your region. We also offer a continuing education program that you can join free of charge. You can register to one or more trainings that you can do at your own pace and receive an electronic certificate of participation. These are all offered by experts, and we have more than 1,500 healthcare professionals using the platform with over 40 trainings available for you. We have trainings on blood cancer treatments, psychosocial aspects of cancer, and more, and we are continually adding to these trainings. Available online are all our educational tools and resources. These are vetted by experts for all the main types of blood cancers, treatments, secondary effects, and more. Our material is available in multimedia formats to address a variety of needs and preferences. They include digital disease booklets, fact sheets, podcast episodes, animated videos, and webcast recordings. By visiting our website, you can place an order for materials that will be sent directly to your cancer center or clinic. Materials can be ordered include disease booklets, service posters, palm cards, and much more. All of these tools can be ordered through our website. You can order tear pads for easy reference to our services or blood cancer literature to inform those affected and the families you support. It is all easy to do and free of charge. Most of our material can also be downloaded through our website. With this handy electronic form, you can order the materials to be shipped to your location. It just takes a few clicks. If you have any questions, please reach out to the community service lead in your region, and we are always happy to help. Emotional and practical support is a priority for the LSC. Our peer support program has been identified as a key service, but many don't know about it. Trained volunteer survivors who are 1 year post-treatment share their stories with newly diagnosed patients or those facing a new treatment option. Age, gender, diagnosis, and treatment are considered to ensure the best possible match. This program helps to build hope, alleviate anxiety, and create realistic expectations. We also have professionally facilitated virtual support groups. These support groups are offered coast to coast and provide an opportunity to the blood cancer community to connect with others who are facing the same challenges from the comfort of their own home. Each participant builds connection through group discussions, sharing coping tools and information to help break isolation. Please visit our website, www.bloodcancers.ca, or reach out to the community service lead in your region for more information. It is now time to introduce our speaker today, Rachel Nielsen. Rachel is a specialty nurse practitioner at the Nova Scotia Cell Therapy and Transplant Program.
Okay, so thank you so much for that, that introduction. And so without further ado, we will start our presentation. So we're going to clinical overview of immune-related adverse events with a focus on cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome. So our learning objectives for today are to define both CRS and ICANS, to discuss the pathophysiology of CRS and ICANS, to recognize the signs and symptoms associated with CRS and ICANS, to understand the diagnosis, grading, and clinical management of CRS and ICANS. And lastly, we will review some case studies for CRS and ICANS to support what we've learned today. So we'll start with an introduction. The use of T-cell engaging therapies are increasing in the treatment landscape for lymphoma. These treatments have led to improvements in overall survival and quality of life for patients. With this, however, comes unique side effects of these therapies, which include the topic of our presentation, CRS and ICANS. Both of these unique side effects are a result of an overactivation of the body's immune system. Both of these can be severe and have the potential to be fatal. It is critical for healthcare providers to have a knowledge and understanding of these side effects for early detection and monitoring. And again, early detection and intervention is key to optimize patient outcomes. So we will first begin with cytokine release syndrome, also known as CRS. So CRS is one of the most frequent and potentially serious side effects of immune effector cell therapy. It is defined as an acute inflammatory syndrome resulting from the large and rapid release of cytokines into the bloodstream. It occurs typically within 1 to 21 days of the T cell infusion. The severity and grade of these symptoms may be related to the degree of disease going into CAR T or other T cell engaging therapies. Causes include immunotherapies, as we know, as well as infections. Just to review, cytokines are chemical messengers or proteins that help stimulate and direct the immune system. And we'll talk about cytokines a little bit later on in the presentation. Risk factors for CRS include the tumor burden that the patient has, the intensity of the lymphodepletion chemotherapy or type of chemotherapies involved, the CAR T cell therapy dose, thrombocytopenia, as well as the type of cell therapy that the patient is receiving. So we'll do a quick overview of the pathophysiology of CRS. So the understanding of the pathophysiology of CRS is incomplete. However, CRS is thought to result from a massive release of cytokines due to the interaction between tumor and immune effector cells. CRS can be induced by the activation of T cells due to therapeutic stimuli with subsequent cytokine release. It can also be caused by the direct target cell lysis or cell death with consecutive release of cytokines. Cytokines trigger a chain reaction, activating innate immune cells such as macrophages and endothelial cells, which further the release of cytokines. This results in a positive feedback loop, inducing further release of cytokines. And this results in an inflammatory response and cytokine storm, which leads to some serious side effects. So signs and symptoms of CRS can be organized into early and late. Important to note that CRS is a spectrum of syndromes which range from mild, such as the presence of an isolated fever, to severe and potentially fatal side effects, such as capillary or circulatory collapse and multi-organ system failure. CRS typically manifests as a fever paired with several nonspecific clinical findings, such as fatigue, headache, rash, arthralgia. Later and more severe cases of CRS can lead to multiple organ dysfunction and failure, or can progress to systemic inflammatory response syndrome, or SIRS, which can be serious and life-threatening. So here's a slide that just outlines the comparing normal cytokine release with CRS or excessive cytokine release. You can see that normal cytokine release does result in a natural immune response and inflammation, while the excessive release of cytokines, such as CRS, leads to an overactive immune response. Again, as we mentioned before, cytokines are part of the healthy immune system. They are proteins released by the body when a threat or stimuli is detected, such as an infection or tissue damage. Examples of cytokines include interleukins, interferons, and colony-stimulating factors. Cytokines help control the growth and activity of both blood and immune cells. One cytokine that plays a key role in the development of CRS is known as interleukin or IL-6. Increased levels of interleukin-6 are associated with higher grades and increased severity of CRS symptoms. As a result, IL-6 has proven to be a therapeutic target as part of the treatment and management of CRS. Inhibition of the IL-6 pathway has proven to be an effective method of resolving CRS symptoms. So a diagnosis of CRS involves the physical exam and vital signs. So this includes your temperature, blood pressure, pulse, oxygen saturation. Also includes routine blood work, such as your CBC, your electrolytes, your liver enzymes, as well as monitoring inflammatory markers. These include your LDH, ferritin, as well as fibrinogen and CRP. Diagnosis of CRS also involves ruling out other potential side or causes of these symptoms, which we will touch on later. As a result, we will do blood and urine cultures to rule out any infection or sepsis, which can mimic CRS. In addition, the use of imaging tests can help support or negate a diagnosis of CRS, such as your chest X-ray, your echocardiogram, etc. So differential diagnosis for CRS, as I briefly touched on in the previous slide. Other differentials can include infection and sepsis. Similar symptoms include fever, hypotension, as well as late symptoms of organ dysfunction. CRS symptoms can also mimic another oncology-associated adverse effect known as tumor lysis syndrome or TLS. And these similar symptoms are your fatigue and organ dysfunction. They can also mimic hypersensitivity reactions in the sense of a fever. It can also mimic other syndromes known as HLH or MAS for fatigue as well as organ dysfunction, as well as pulmonary embolism. So fever, low blood pressure, as well as hypoxia can also be both a sign of a pulmonary embolism as well as CRS. The next couple slides will include different grading systems used by various institutions. And this is how we grade CRS, and this helps to guide our treatment. Although these may vary slightly, they typically follow the same path. For the purpose of this presentation, we will focus on the first column to grade CRS. So this is the American Society for Transplantation and Cellular Therapy. For grade 1 for CRS, grade 1 includes a fever, so a temperature of over 38 degrees Celsius. It's important to know that grade 1 does not include hypotension or low blood pressure or hypoxia or decreased oxygen saturation. So whenever I think of grade 1 CRS, it's an isolated fever or isolated temperature above 38 degrees. Going to our next CRS grade, grade 2 includes a fever or a temperature of equal than or greater to 38 degrees Celsius, as well as the presence of hypotension, but this hypotension does not yet require vasopressors. In addition, this may include or not include hypoxia, which requires only low flow oxygen by nasal cannula. So grade 2 is a fever plus hypotension plus or minus hypoxias. Grade 3 CRS is a fever or a temperature greater than or equal to 38 degrees Celsius, as well as the presence of hypotension, which requires one vasopressor with or without vasopressin. It also may or may not include hypoxia, which requires low flow nasal cannula, face mask, non-rebreather mask, or a Venturi mask. Grade 4, or quite serious CRS, includes a fever of greater than or equal to 38 degrees Celsius. This grade 4 CRS requires multiple vasopressors except vasopressin, and or hypoxia requiring positive pressure, for example, your CPAP, your BiPAP, intubation, or mechanical ventilation. And grade 5 CRS, not really applicable to this one, but really is just death. So for the clinical management of CRS, for prophylaxis, prior to the administration of T-cell engaging therapies, patients may receive prophylaxis for CRS, and these may include antipyretics such as Tylenol, antihistamines, as well as corticosteroids. This often varies throughout institutions as well as depending on what type of T-cell engaging therapy is used. Anti-cytokine therapy is integral in the treatment of CRS. And for people receiving CAR T-cell therapies, this is where your tocilizumab comes into play. So continued clinical management of CRS. This includes intravenous fluids. I did put a star on this slide because it's important to know that these patients are at high risk of developing pulmonary edema. So we don't want to load these patients with a lot of IV fluid. Typically, if their blood pressure hypotension does not respond to 1 to 2 liters of fluid, we're looking at getting ICU on board for this rather than with patients going through sepsis and we're giving them high amounts of fluid. These patients, again, are at high risk for developing pulmonary edema, and we want to be cautious of the amount of fluid that we give them. Further clinical management involves antipyretics such as Tylenol, antihistamines such as Benadryl, corticosteroids such as prednisone or dexamethasone, and again, the treatment with anti-cytokine antibodies such as tocilizumab. And as I mentioned before, higher grades of CRS or severe symptoms may require ICU support and transfer. So again, clinical management, anti-cytokine therapy such as tocilizumab. The mechanism is inhibiting the pathway of IL-6, and examples of this include tocilizumab, ciltuximab, as well as anakinra. Corticosteroids. Corticosteroids are used both in combination with tocilizumab or other anti-cytokine therapy, as well as alone. They also have anti-inflammatory properties. Examples of these include dexamethasone and methylprednisolone alone. Examples of corticosteroids frequently used in the management of CRS include dexamethasone and methylprednisolone. The next few slides will outline CRS occurrence, rates of grade 3 or higher CRS, medium times and durations, as well as the grading system used with a specific T-cell engaging product. I won't go through these slides in detail, but they are a great reference to use when using a T-cell engaging therapy. And they are a quick overview of what you can expect while using this specific therapy. So we'll just go through them. So the first one is Yescarta for the treatment of relapsed refractory diffuse large B-cell lymphoma. The second one is Breyanzi. Next is Kymriah. And now blinatumomab, which is used in your relapsed B-cell ALL. Teclistamab, which is often used in the treatment of relapsed refractory multiple myeloma. Lunsumio for follicular lymphoma. Kimtrac, this is for metastatic uveal melanoma. So next we will go on to a case study to further support our learning of CRS. So SS is a 58-year-old male who is day +2 post-Yescarta. This is a CAR T-cell therapy treatment for primary refractory diffuse large B-cell lymphoma. At 8 o'clock, he develops a temperature of 38.5 degrees Celsius. The remainder of his vital signs are stable, and his blood pressure is stable at 138/76. A septic workup is completed, and SS is started on broad-spectrum IV antibiotics and given Tylenol for his fever. Throughout the morning, he experiences intermittent fevers with his temperature max of 39 degrees, with no other changes in vital signs. He reports feeling fatigued and warm, but denies any other significant symptoms. He remains alert and oriented, and his ICE score is 10 out of 10. And we will talk about the ICE score a bit later on in this presentation. So according to the grading criteria, SS has CRS grade 1, and this is based on the presence of an isolated fever with no other changes in vital signs such as hypoxia or hypotension. At this time, SS is treated conservatively with Tylenol, and his healthcare team waits for the results of his septic workup. Anti-cytokine treatment, such as tocilizumab, is not initiated at this time, but will be absolutely considered if he develops any worsening signs of CRS, and this would include hypotension, hypoxia, etc. So key learning points for CRS. CRS develops when the immune system overreacts to a stimuli and results in a massive release of cytokines into the bloodstream. CRS can be induced by direct target cell lysis with consecutive release of cytokines or by activation of T cells due to therapeutic stimuli with subsequent cytokine release. CRS is a spectrum of symptoms ranging from isolated fever to multi-organ failure. CRS is treated with anti-cytokine therapies, as well as steroids and supportive care measures. And next, we will touch on ICANS, or immune effector cell-associated neurotoxicity syndrome. So ICANS is the second most common toxicity associated with T-cell engaging therapies. Similar to CRS, ICANS is a syndrome of neurological side effects involving pro-inflammatory cytokines and neuronal injury. ICANS presents as toxic encephalopathy and is potentially life-threatening. Mechanisms for ICANS remain unclear, but are thought to be related to the disruption of the blood-brain barrier due to inflammation and the presence of cytokines. ICANS typically occurs later than CRS, usually within 1 to 3 weeks of T-cell infusion. However, this may overlap with CRS symptoms. Risk factors for the development of ICANS include a high disease burden, the type of lymphodepleting chemotherapy, the presence of high ferritin levels, in addition to the presence of high cytokine levels. So severe CRS is actually a predictor of the development of severe or higher grades of ICANS. And a study has shown that 90% of patients that develop ICANS previously had some grade of CRS. So the next two slides will focus on the pathobiology and pathophysiology of ICANS. Again, despite the clinical features of ICANS being quite recognizable, the pathophysiology remains poorly understood, but is thought to be related to pro-inflammatory cytokines, disruption to the blood-brain barrier, and neuronal injury. ICANS may start with the production of pro-inflammatory cytokines and the activation of bystander immune cells in the tumor microenvironment. These inflammatory cytokines diffuse into the bloodstream and disrupt the blood-brain barrier. Since these cytokines can cross the blood-brain barrier, they can result in harmful activation of microglia and subsequent neuronal damage. resulting in the neurological symptoms that we will talk about. Signs and symptoms of ICANS, like CRS, can be divided into two categories of early and late. Early symptoms of ICANS include expressive aphasia, dysgraphia or impaired ability to write, tremors, impaired attention, apraxia, lethargy, and headache. While late signs and symptoms include more serious ones, including global aphasia, obtundation, stupor, coma, seizure, and cerebral edema. The diagnosis of ICANS involves a thorough physical examination and assessment of vital signs, which includes neurovital signs, the use of the ICE score, typically every 8 hours, which we will talk about in more detail, fundoscopy, EEG, neuroimaging, a lumbar puncture, and it is often recommended in more severe grades of ICANS to consult our colleagues in neurology for diagnostic as well as treatment guiding. Similar to CRS, symptoms of ICANS can mimic other syndromes that patients may develop. For infection and sepsis with high fevers can cause confusion, which can mimic ICANS. We want to obtain blood cultures as well as other blood work during this time. Symptoms of stroke can present similarly to ICANS. Any stroke-like symptoms should require an urgent CT of the head. The use of pain medication may mimic ICANS by causing confusion or lethargy. It's important to review medication administration records for the past few days to assess whether or not patients are receiving these medications. Many patients being treated with T-cell engaging therapies may have non-essential medications such as sleeping aids or benzodiazepines put on hold during the acute phase of their T-cell engaging therapy where they may be more likely to develop ICANS. And this is again to not mask any symptoms of ICANS that may be caused by the medication. Another diagnosis that must be ruled out is any new or progressive disease in the central nervous system. And these can mimic symptoms of ICANS and should be further evaluated through imaging or a lumbar puncture and cytology. So grading ICANS involves the ICE assessment tool for grading ICANS. So the ASTCT group developed the current consensus guidelines for grading ICANS. And the first component of this is the immune effector cell-associated encephalopathy, or ICE tool, which evaluates patients based on 5 factors. These 5 factors include orientation, naming, following commands, writing, and attention. Patients are scored on each factor with a total score of 10, with 10 being the best, or no symptoms of ICANS, and 0 being the worst, or severe ICANS. The ICE score results are included as a domain in the ASTCT consensus grading system, along with additional neurological factors such as level of consciousness, motor symptoms, presence of seizure activity, and signs and symptoms of elevated intracranial pressure or cerebral edema. So the next few slides will outline the grading of ICANS, and this is based on the ICE score and the other absence or presence of other neurological symptoms. Remember that a high ICE score of 10 indicates no symptoms of ICANS, where lower scores indicate the presence of ICANS. So a ICE score of 7 to 9 is grade 1, 3 to 6 is grade 2, and you can see the other symptoms that are associated with these as well. Grade 3 is 0 to 2, so we're getting into more severe levels of ICANS during this time. These slides are a great reference and tool in quickly identifying what grade of ICANS a patient has. So getting into grade 4 ICANS is a severe level of ICANS, as you can see with the associated symptoms. And these patients are often already, if not on their way to ICU for further monitoring and intensive treatment. So the clinical management of ICANS. The management of ICANS continues to evolve and is an area of ongoing research. Treatment of ICANS varies by individual product as well as the grade and severity of symptoms. The hallmark treatment for ICANS remains the initiation of high-dose corticosteroids. There's also prophylactic medications used with some products to help mitigate seizures in patients with ICANS, and this involves the use of the medication Keppra. High grades of ICANS may actually require lumbar puncture or intrathecal medication administration to mitigate serious symptoms. Similar to CRS, high grades of ICANS as well as severe symptoms may require ICU support and transfer for closer monitoring and intensive treatment. So similar to our section for CRS, the next couple slides will include ICANS occurrence, presence of grade 3 or higher ICANS rates, as well as the median time and duration of ICANS in specific products. So again, these are great references to use based on the product that you are using in your center. So similar to CRS, these next few slides are an overview of specific T-cell engaging therapies. They outline the ICANS occurrence overall, grade 3 or higher ICANS occurrence, as well as the medium time to onset and duration of ICANS. Again, these slides are a great reference to refer to when using specific T-cell engaging therapies in your center. The first drug here is Yescarta for relapsed refractory diffuse large B-cell lymphoma. Next again is Breyanzi and Kymriah for, again, relapsed refractory diffuse large B-cell. Blinatumomab for relapsed refractory ALL patients. Teclistamab. Lunsumio. Kimtrac. Doesn't really have any evidence of ICANS. And next, we will go into our ICANS case study. FR is a 61-year-old female, again being treated with Yescarta. She's day +8 post-infusion for the treatment of relapsed diffuse large B-cell lymphoma. At 10 o'clock, when the RN is performing FR's ICE score, she incorrectly answers some of the orientation questions and is unable to count backwards from 100 by 10. Her handwriting is normal at this time. The RN gives her an ICE score of 6 out of 10. FR remains pleasant and alert with no changes noted in her level of consciousness. FR's vital signs are stable. She has not had a fever for over 4 days and remains on broad spectrum IV antibiotics. So according to the grading criteria, FR has ICANS grade 2 and this is based on her symptoms as well as her ICE score. As a result, she is promptly treated with dexamethasone, 8 milligrams IV, every 8 hours for 3 days, with complete symptom resolution. At this time, her ICE score returns to 10 out of 10. Neuroimaging through a CT scan of her head was unremarkable. Supportive care for FR involved frequent patient checks and reorientation, as well as the initiation of other safety measures, such as proper lighting, the use of a bed alarm, etc., while she is in this disoriented state. Key learning points for ICANS. ICANS is a syndrome of neurological side effects thought to involve pro-inflammatory cytokines and neuronal injury. The underlying mechanisms of ICANS are not fully understood, but may be related to disruptions in the integrity of the blood-brain barrier. ICANS, like CRS, is a spectrum of symptoms ranging from mild, such as inattention and dysgraphia, to severe in the form of seizures, obtundation, and coma. The hallmark treatment of ICANS remains high-dose corticosteroids, but this continues to be a topic of ongoing research. Thank you for attending, and I hope this presentation was beneficial in your understanding of CRS and ICANS and T-cell engaging therapies.
Thank you so much, Rachel, for this presentation. And to you who are listening to us, I hope you enjoyed it as well. We invite you to access the continuing education platform to view our other training courses. This event was made possible thanks to the continued support of AbbVie. And finally, I would like to remind everyone that we are here for the blood cancer community. Please don't hesitate to order our tear pad for free and to contact us if you need more information or support. We hope you have a wonderful rest of your day. Thank you.